Could a simple blood test detect breast cancer recurrence after you thought you were cured? New real-world ctDNA data shows it changes management in real time. At the MOASC 2026 annual meeting, we sat down with Dr. Marla Lipsyc-Sharf from UCLA to break down the numbers and what it means for your patients. In 3, 2, 1. How reliable is ctDNA for detecting minimal residual disease years after early-stage breast cancer?
Thank you. This is a great question and does seem to vary based on the patient, the test, the subtype of breast cancer, and many other factors. What we do know is that patients that are at high risk of recurrence years after diagnosis of their initial disease can have detectable ctDNA from anywhere from months to up to 3 years, sometimes even longer, prior to the diagnosis of a metastatic recurrence. And so one of the things that we encourage, if patients are doing regular ctDNA testing, we know that serial testing at multiple time points, makes the testing more accurate. And that's something that if you're testing years after diagnosis, you can factor into in terms of the accuracy of the test.
In your real-world data, how often does a positive ctDNA result change clinical management?
So in our real-world data, we can see that providers and patients elected to change management based on a positive ctDNA test more than 80% of the time. So most of our patients with a positive ctDNA test are changing some amount of management, whether that is doing imaging, which is otherwise not recommended for adjuvant breast cancer setting, changing medications in some capacities, getting a second opinion, enrolling on a clinical trial, or other changes in management. We do see that people in clinical practice currently are acting on positive ctDNA tests.
Which breast cancer subtypes appear to benefit most from routine adjuvant ctDNA monitoring?
We are figuring this answer out as a field. I think there are different strengths of ctDNA testing for each of the different subtypes. In particular, I think one of the potential strengths of monitoring for ctDNA in ER-positive disease is that there is a potential for a longer lead time, meaning that we can detect ctDNA perhaps quite a long time before their clinical radiographic recurrence would otherwise be detected. And so we think of that window as a potential window to intervene on MRD, and it may be longer with ER-positive disease. One of the hard things about testing in ER-positive disease is that you need an ultrasensitive test. And fortunately, we are getting ultrasensitive testing that is improving all the time, constantly in this space. And so I think that testing in the ER-positive space will be improved because of that, and our clinical trials will be improved because of that. For triple negative and HER2-positive breast cancer, sometimes we have less of a potential lead time or a window in which to intervene, but the ctDNA levels can sometimes be higher. And so that's a potential advantage of testing in that space. One of the things we're trying to learn also is, does it make a difference how often we get this test by subtype? And what we have learned from our real-world data so far is that the negative predictive value for each of the different subtypes appears to be excellent in all of the different subtypes, specifically in our real-world data from using the Signatera database, which is fortunate. That means that if patients have a negative ctDNA test, really with any subtype, the chance of having a recurrence in the next 3 to 6 months is less than 2%, which is pretty good. So to summarize, I would say different strengths and weaknesses by subtype, and really thinking about what you're getting the test for and what are the interventions you're studying.
What would success look like in the ongoing ctDNA-guided interventional trials like DARE or TRACKER?
Great question. We one day want to see that ctDNA testing and therapeutic intervention based on ctDNA testing improves breast cancer survival or improves quality of life. That would be a tremendous success and a huge win for our patients.
How soon do you expect ctDNA-guided therapy to become standard in adjuvant breast cancer care?
Another great question. How soon to become standard? I would say my hope is that we will be able to see evidence of improvement in breast cancer outcomes or quality of life in the next 5 years, such that ctDNA could become part of the standard of care in that time frame. That would be a really nice advance for our patients. One thing we can do as oncologists is to educate our patients about ongoing clinical trials and have the willingness to participate ourselves in ongoing clinical trials for ctDNA detection and therapeutic intervention after ctDNA detection. We are now coming upon the eve of one of our first ctDNA company-sponsored trials. So the Natera is sponsoring an interventional clinical trial, and there are multiple ongoing clinical trials that are separately studying in therapeutic intervention after ctDNA detection. And so to the extent possible, patient and oncologist willingness to participate and advance this field is critical. So thank you for considering that, and I would encourage people to continue to do so.
If you liked this video, you may also like the suggested video, Near-Wrap a Rib versus Placebo ctDNA Surveillance in High-Risk Breast Cancer Patients, the ZEST trial. In the description, you will find a link to a web post companion for this video on oncologytube.com. Thank you for watching.